Good day, and thank you for joining today's webinar. I am Sherilyn Francis with the Partnership for Diabetes Health Equity. We encourage you to connect with us at www.diabeteshealthequity.org, and you can tweet us at P4DHE using hashtag PDHE. The Partnership for Diabetes Health Equity at the Morehouse School of Medicine is a collaboration between the National Center for Primary Care and the Bristol Myers Squibb Foundation around diabetes best practice dissemination and scalability. PDHE represents the bridging of what we call the three elements: quality team-based clinical care, community engagement, and health outcomes driven by data collection and analysis. The cornerstones of PDHE are Learn, Share, Connect, and we accomplish this through capturing lessons learned, case studies, concrete tools, templates, and by creating environments that promote networking and collaboration. I now present to you today's webinar entitled Addressing Depression and Disease Distress in Patients with Diabetes in Federally Qualified Health Centers, the EPIC-4DM Project, presented by Sophia Alirez, Dr. Chandra Brown-Levy, Ms. Allison Dreyer, and Dr. Bethany Kwan. In compliance with the ACCME guidelines, the following speakers do not have financial or other relationships with manufacturers of any commercial service discussed in this educational activity. The objectives for today's webinar are to describe diabetes distress and its effects on patients with disparities, discuss overlap and distinguish between distress and depression, and evidence-based approaches to intervention in primary care settings, to distinguish screening tools and appropriate use in federally qualified health centers, and to explore the EPIC-4DM project. And now, Dr. Brown. And now, Dr. Brown.
And the 2015 position statement of the American Diabetes Association is that care for patients with type 2 diabetes should require a variety of different therapy workings, including working towards healthy weight management, blood pressure control, tobacco cessation, if that's a factor. There's a lot of work that needs to be done in partnership with patients, and so this often requires a team approach. So we're going to talk about that today. We do know that patients with diabetes benefit from comprehensive diabetes self-management education and self-management support in primary care. So we're going to talk a bit about how we worked to attain that through our program. A lot of people discuss how depression and diabetes go together, but what's not discussed nearly as much is diabetes distress specifically. So we want to spend a bit of time talking about that and what is diabetes distress. So this is the sense of being overwhelmed by the requirements of managing a chronic disease, and we're going to talk about that in the context of diabetes specifically. So this includes a variety of multifaceted concerns. Specifically to diabetes, this includes regimen burden and interpersonal burden, and this could be related to interacting with the healthcare team, family, friends, really any interpersonal relationships, as well as emotional burden, and this can be related to mood complications, specifically low mood, anxiety, for example. And then the healthcare navigation burden. So oftentimes patients wondering, is this a question that I should be asking? Who should I be asking this to? Who can help me with this? When is this something I should bring to my team? When is this something I should just try to manage on my own? And so trying to navigate the healthcare system, and specifically if they are going to bring that to their healthcare team, which team members are going to be best suited to help them address those concerns. And so it becomes very challenging over time. This can interfere with adherence and self-management and adversely affects quality of life and disease control, as navigating through these waters is challenging for the most part. So diabetes, distress, and depression is something that's really important to spend some time distinguishing. oftentimes, if you're in if you're lucky enough to be in a clinic that has the opportunity to screen, there are some screening measures that can help distinguish between diabetes, distress, and depression. And so some screening assessments that you may be familiar with, oftentimes people use the PHQ 9 and start off with a PHQ-2 just to do a screening for depressive symptoms. And this isn't a diagnostic tool, but it is a screener. Similar to that, the diabetes distress scale can help to determine if diabetes-specific distress is present for patients. And so distinguishing between these two is really important because oftentimes overlap can be present. But if we target diabetes distress, then we can alleviate the symptoms that go along with that. Whereas if we target the depression specifically, that can be alleviated. However, if we don't distinguish between the two, oftentimes gains in either direction won't be met at the level that they could be if you targeted them specifically. And just remembering that depression is a clinical diagnosis, and so you don't want to go just based on a screening tool alone, but if a PHQ-9 is coming up positive, digging into that a little bit deeper and determining whether or not a clinical diagnosis is met is important to distinguish. There are a variety of different interventions that can be made with diabetes distress. This is something that patients and providers and healthcare teams can take action with and help patients to feel much better, but it does have to be targeted specifically. Some effective therapeutic interventions include CBT, or cognitive behavioral therapy, ACT, or acceptance and commitment therapy, and behavioral activation. And self-management support goes along with all of these, and Dr. Kwan's going to speak more about that specifically in just a moment. We've found that the more you can activate a team around these elements of care, oftentimes the better a patient can do and the better the team can feel about their efforts towards improving the health of the population of their clinic. And the last thing we wanted to, at least I'm going to discuss during this webinar for now, is what are some opportunities for team-based care, and how can you distinguish this based upon the level of distress that the patient is presenting with. And so you can see across the top that we broke this down into 3 categories. So looking at all patients with diabetes, but perhaps no distress is present, and then bumping that up to a moderate or increasing level of distress, and then finally, what do you do when there are high levels of distress present? So for all patients, it's important to have ongoing acknowledgement and education regarding support for distress, and that this is an expected part of having diabetes. And so prep people that as this comes up, this is something that they can seek help with and they can get some support around. This can be discussed during clinical moments, critical moments in the disease course, specifically perhaps at diagnosis or when starting insulin or experiencing various complications. So there might be some points that this can be brought up where it would be more well received. But it can also happen just in the context of a regular clinical encounter. Maybe things are going pretty well, but it's just something that is important to discuss. And this can be done in the context of diabetes education specifically, but also standard clinical encounters. When there is moderate or increasing levels of distress, the importance of continuing screening to monitor that is important, and then also distinguishing between distress and depression so that you can intervene appropriately. Addressing the distress directly through problem-solving approaches, family interventions, if possible, and then coordination with your care team. And also this can be done in the context of self-management support, behavioral health encounters, but also standard clinical encounters. This can be done in an outpatient as well as an inpatient setting. And then also high levels of distress. So again, assessing and distinguishing between the distress and depression, and also considering other multiple comorbidities that could be playing a role in the presentation. Looking at more intensive interventions, this could be medication therapy, psychotherapy with continued consideration of diabetes in context is very important. And then as you see efforts towards more integrated care, if you can engage your team, if you have a multidisciplinary care team that can help use their expertise, whether it be social workers, psychologists, your pharmacy team, whatever team members you have that can help support in the care of the patients, particularly when their distress becomes higher, is always beneficial. So at this point, I would like to turn the presentation over to Dr. Kwan, who's going to speak to you more about self-management support.
All right. Thank you, Dr. Brown-Levy. So I'm going to talk a little more about self-management support for patients with diabetes, and specifically how it relates to and can be used for patients that have depression or distress. So diabetes self-management support, or SMS, in primary care has multiple components. First, it involves education and counseling patients. Importantly, it also involves collaborative goal setting and action planning with patients. That it's not just about education, it's all about having a collaborative relationship with patients to figure out where do they feel like they can take some action, where do they feel confident, where are there some barriers, and how can you help them work through some of those barriers. The use of self-management support is often supported through various health information technology and information systems, such as registries that help you identify patients, systems for doing assessments with patients to identify what sorts of resources or areas of assistance that they need. And also it involves referral often to community-based programs, as well as to the interdisciplinary care team that you may have in your practice or that you may have access to outside of your practice. Project, we specifically use the 5 A's model of self-management support. And the 5 A's, as you see, is a dynamic process over time in which you conduct assessments with patients, identify what their needs are, advise them on where they need to make changes, agree collaboratively on goals, assist patients with identifying barriers, in particular supports they may need, including resources, and then importantly arrange for follow-up. When are you going to close that loop? How are you going to do that? Whose responsibility is that? And all these things come together to specify a patient's personal action plan with their goals, their barriers, the follow-up plan, and additional resources you're planning to connect them to. Okay. So our 4DM project, this stands for Enhancing Patient Practice and Community Capacity for Collaborative Diabetes Depression and Diabetes Distress Management. 2 main goals for our project were to improve self-management, mental and physical health in the experience of healthcare for patients with diabetes and depression or disease distress, and to link patients with diabetes and these additional health concerns to both practice and community-based resources. So our intervention had multiple levels. At the basic, at the core, our goal was to encourage the use of self-management support using something called the Connection to Health web tools that I'll show you in just a moment by an integrated care team for patients with diabetes. Layering on top of that, after you've done the goal setting, identify what services are available within your clinic. We've heard from patients engaged in this research and in this topic area in general that first, whatever you can get within the clinic so they don't have to go anywhere else, utilizing what those clinics already have set up to help meet their patients' needs, like health education, behavioral health providers or BHPs, that this is a really good, important place to start. And then beyond that, linking to external self-management support resources. And for this, we developed a resource directory that's incorporated into the action planning process within the Connection to Health tool. So multiple layers, and I'll talk you through each layer. To evaluate our project, we used REAIM, which stands for Reach, Effectiveness, Adoption, Implementation, and Maintenance. The important message that REAIM brings is it's not about efficacy. It's really about making sure that your project, that your intervention can work in real-world healthcare settings. And that is often where a lot of interventions have challenges, where there are a lot of barriers. And so really understanding the adoption at the practice level, the implementation at the practice level, how many patients they're actually able to reach, ultimately informs the impact of your intervention. And so we are specifically today talking about reach and implementation. Okay. So here is the Connection to Health tool. The Connection to Health tool was developed through a grant through NIDDK and by some colleagues of ours, and we added to it for our project. And what you see here is the first component, and in the first of the 5 A's that Connection to Health helps with. And so patients complete an assessment, and I want to say brief, but for some patients it turned out not to be so brief, as we'll talk about. And then it assists with the advising. You can see this patient grew and shrunk multiple times. This is just a test patient here. And you can see that it indicates where patients are struggling. A nice component of the Connection to Health tool is that it produces a clinician report that indicates both the patient's priorities that they'd like to discuss with their team. This patient wanted to discuss mood and my health concerns. This is the way we refer to diabetes distress. It also brings up potential high-risk issues and indicates how you might respond clinically when you have these particular priorities. Here's the resource directory that we incorporated into our tool. And when the patients are doing action planning, they're able to bring up this list of resources that are in their area, that are close to their clinic, and that are targeted to the particular goals that they would like to work on. Here's the template for the action plan. You can see kind of in the background here that patients select goals, they identify specific strategies for meeting their goals, and then they're able to bring up and select the resources that they would like to use. And in this instance, we included both the internal and the external resources so that patients and those working with those patients could use this as an opportunity to determine whether there was an internal resource that could meet their needs or if they needed to go outside. Okay, so we worked with the Metro Community Provider Network and 4 practices within MCPN to implement self-management support using the Connection to Health tools. So this was a practice level intervention. All of the training was done at the practice level with staff and clinicians with the practices. As part of a larger study, these practices were randomly assigned to either a control condition, which are not reported here, to a condition in which they received education on self-management support and how to use Connection to Health tools. And because we know implementation is so challenging, an additional set of practices received the same education, but they also received practice coaching or practice facilitation. And practice coaches, there's some tremendous resources out there about what coaches can do, but we use them to help inform local implementation. So helping the practices identify specific roles, workflows, and overcoming barriers to implementation. We also found that it was critically important to having organizational leadership engaged in implementation, planning, and decision-making. And our MCPN representatives here today are those organizational leadership who really worked very hard to figure out how to overcome the barriers at the local level. Okay. We also provided more targeted training around depression and disease distress. So again, this was a practice level implementation. We talked about implementation of evidence on depression and distress screening and treatment, much like what Dr. Brown-Levy presented earlier. This was an organization-wide training that included behavioral health providers, health educators, medical providers, patient navigators, care coordinators, and more. So this is another important thing that we have found in our prior work, is that if you want a group to act like a team, if you want a clinic to bring all members of a team in, then they all need to participate in those trainings. And this was a 2-hour training on similar to information to what Dr. Brown-Levy presented. We also did additional targeted training for behavioral health providers. We did 2 one-hour one-on-one trainings with a clinical psychology intern specifically. And there was also a coaching session with the practice coach, again on workflows and overcoming barriers. Okay. So here's a brief outline on how the depression and distress training went. We presented some case studies, encouraging the group to think through what their own experiences were like in identifying distress and depression with patients, and then directing them to appropriate care team members. Importantly, we helped make the connection between mental and physical health. This is still a challenge, is helping people come out of their silos, outside of their regular ways of thinking about the distinction between mental and physical health, and really thinking about the interrelationship between those two. We talked importantly about the clinical diagnosis of depression, how you go about determining that, and similarly, how you go about determining diabetes distress, doing that assessment, doing that differential diagnosis, and identifying appropriate interventions. And then finally, focusing on team-based care. Okay. So here was what we found when we tracked the implementation of the Connection to Health tools and the use of self-management support for patients with diabetes, and ultimately prediabetes. So the 2 practices that had coaching clearly did much better overall than the practices that did not have coaching. We ended up with 168 patients with diabetes who completed assessments, and 84 patients with, so 168 prediabetes, 84 with diabetes, so 252. Much fewer action plans. Already we're seeing how we're having barriers in implementation. It was very challenging. So about 2/3 of patients were actually getting the action plans completed. So within these action plans, here are the different types of self-management goals that patients decided to fix or decided to address. The vast majority of patients chose dietary changes, exercise, and weight loss. Interestingly, very few patients selected improving mood or improving stress as their self-management goal. And we'll talk more about potential implications and interpretations of that a little bit later. Another thing we looked at was how many of these action plans specified a resource and whether these were internal or external resources. So we saw about 70% of action plans did include a resource, did select a resource from that directory. About 16% were internal resources, including health education, behavioral health, or the patient navigators, or external resources, most of which were rec centers and gyms. And then also quite a few liked diabetes meetups. So if you haven't heard of diabetes meetups, I encourage you to look them up. They're a great way for patients to get social support, which we have consistently identified as being something of value to patients with diabetes. There are some questions here we get back to. I just want to mention that the diabetes distress tool does come in Spanish as well.
What tools have you seen that address or assist persons with diabetes and a disability? Excuse me.
And a disability.
Yes, what we can do is, if you want to, well, okay. That one is actually from Barbara. So Barbara, if you'd like that clarity,
the question about
can type that in
the website
the Q&A box, and you can proceed, and we will be taking questions and have periodic stuff.
Not knees up, but meetups. Meetups are their website that you can go to. It's about more than just diabetes. You can find meetups for anything, you know, learning how to plant a garden to starting a new business. Okay, good. All right. Okay, so what we found in terms of diabetes distress was that nearly 2/3 of patients screened positive for disease distress, compared to about 25% screening positive for depression. although as I mentioned earlier, very few patients self-selected depression or distress as a self-management goal. And so we felt like really additional efforts would be needed to address depression and distress, and identifying members of the team who felt comfortable raising that issue was not always easy. And so as you'll see in the MCPN experience that we're about to hear about, figuring out how to flag other members of the care team, involve other members of the care team so that they could address these was an important aspect of the implementation. Oh, great. And I see someone posted the diabetes meetup link. Okay. So now I'd like to turn it over to our MCPN colleagues to talk about their own experience in trying to take the interventions, the trainings that we provided, and make it their own. So how did they go about implementing connection and self-management support in their setting? So with that, Sophia Aliris will take us off.
Good morning, everyone. I want to first of all introduce you to Metro Community Provider Network. We are also known as MCPN. We are a federally qualified health center currently serving in 5 different counties, from a single clinic in 1989 to what we've grown into now with 25 health centers located around the Denver metro area. And 3 school-based health centers providing primary care services, dental, pharmacy, social work aspects, and behavioral health services. One of our branches, which is our community services department, provides the wraparound services for our patient population. This includes our health education teams, patient navigation, care coordination, and as part of the project, our care coordination teams was to guide patients through and around barriers in healthcare systems to ensure timely diagnosis and treatment. As part of the implementation phase of this project, the original team recognized that the patient navigation team was should be an essential member of this team, and so then they offered to bring them on to help them collect the patient surveys. Oh, there we go. As part of the project, we have 4 clinic locations that were chosen to be integrated into the project and collect initial data and surveys. And so MCPN's teams are comprised of clinicians, behavioral health providers, health education teams, and at that time we had a community health corps team which was also brought in to help initiate the collection of the surveys. As Bethany mentioned earlier, Dr. Kwan mentioned earlier, we were having some difficulty getting the teams to come together to figure out the best practice in order to collect the surveys and figure out the best way to kind of navigate the folks through this process. And so initially, as I mentioned, we brought in the patient navigation team to kind of be that hub where all the patients would flow through after collecting the surveys, identifying what the patient's barriers were and what needs needed to be addressed according to the Connection to Health screening tool, then were referred to the various departments. So referrals were sent to the behavioral health team, the health education team, and our clinician report was then reviewed by our medical providers so that they could identify specific areas. And so what I'd like to do next is turn you over to Allison Dreyer, who is our patient navigation manager, and she can talk more specifically about what the patient navigators did, and since it was really a new role to our organization, how we were able to implement them into this project.
Hello, everybody. Let me switch to my slide. So as Sophia was the patient navigation is relatively new to MCPN. Began in around January of 2015, so about halfway through this project. The primary job of the navigators is actually to link patients with resources and to kind of do all of the extra stuff that doesn't necessarily get done within the provider visit. So in terms of the connection to health and 4DM model, the best example of success, as you can see from my slide, is actually on the left with Shansei. So he had just started with patient navigation, and he was at a practice that had coaching, and he works at a mid-sized family practice clinic with 3 providers. And the way that he was introduced to this clinic was actually through this project. So he basically looked at the schedule, found all of the patients that had a diagnosis of diabetes and met with them, and he was able to get, kind of the best results. All the rest of the 3 navigators that were part of the 3 other practices had a little bit different situations. Most of them had already been integrated into the clinics, and so if you all are familiar with patient navigation as like a general model, they get used for a lot of different things, not just, identifying diabetes distress and all of that kind of stuff. So we have Mallory. What she did, her and the behavioral health professional she worked with, they kind of tag teamed to meet with patients to get the action plans done and the surveys done. Mackenzie was part of a practice that had coaching, but was actually integrated prior to, and then we had Cassie over at South Aurora, and she actually worked predominantly with pediatric and OB patients, doing kind of maternal and child health. So she probably had the least amount of patients that she was able to actually work with, which accounts for her lower numbers. So basically, the best example is, when you have somebody that's dedicated to providing the surveys, doing the action plans, doing the follow-up, you have a really great result. And you can see that with the numbers that Shansei was able to meet. But one of the most utilizable tools that we had from this project was actually the clinician report that Bethany or Dr. Kwan was talking about earlier. The clinician report is a quick and easy thing to look at, to scan and say, oh, this patient, scored really high on the PHQ-8. They need to see a behavioral health professional, or, they're really having trouble with their meds, or they're having trouble, following. A good example of how that clinician report really worked well for a patient. Mackenzie actually, who was at our Lakewood clinic, she had a situation where the patient had seen their provider, they had gone through the visit, and then she came in and did the survey with them. And on the clinician report, it actually scored that, or had a message that the patient had scored high on the PHQ. And so, Mackenzie, being quick thinking, she went to the behavioral health professional and let the provider know, and they went in and talked to the patient, and it was discovered that the patient actually had a suicide plan, and they were able to get that patient the help that they needed. And so, stuff like that, kind of gets missed when it comes to the difference between, depression and diabetes distress. And so it was a really fantastic example of, how this is, able to be utilized. So I'm going to switch over back to Sophia. 1 second here.
I apologize. We're having a little bit of technical issues, so we're having to share the headset here. So I do apologize, but I did want to go over a little bit about the clinician tool that has been mentioned a few times already, and as part of the completion of the survey. The clinician report was extremely helpful in identifying specific areas, as Allison mentioned, especially with the one particular patient. Although it was a great tool, it posed a little bit of difficulty for us because the systems did not interface with one another. So our EMR and the connection to health tool were completely separate. And so the form was printed out of the connection to health tool and then had to be physically scanned into our EMR. And then once it was into our EMR, then it had to be routed over to the clinician who then would review that. Because it took so many steps to get that into our system, oftentimes the patients had already left from the visit, and then we were having to recall patients back in. So it did pose a little bit of an issue for us, although we did get some really great takeaways from the project. There, as part of the screening tool, as a part of the survey, there was the Diabetes Distress 2 questions that if they scored positive on those 2 questions, then it led into a larger questionnaire survey to determine whether or not the person was actually experiencing depression or distress as a result of their diabetes. And so at that point, if it was related to distress in their diabetes, it was the health educator and the behavioral health provider working in tandem so that they could address those behavior issues and also kind of deal with some of the stressfulness of being recently diagnosed with the disease. So they could deal with that. And then if it was a depression issue, the team would then work very closely with our behavioral health folks to work through those issues. But it was a really great tool that we definitely would love to have had implemented into our EHR had there been an interface. But we are actually in the process of using the Diabetes Distress Questionnaire, and implementing those 2 questions into our EMR currently as part of our flow for our health educators to then identify the distress and work with the behavioral health folks. So we were able to use some of the tools that were developed out of this project and implement them into our everyday process. The other thing that I do have to say is one of the successes and one of our takeaways is initially we did not have a group visit at our Inglewood location, which was one of the sites that was chosen for the project. And as a result of this project, it really actually got us thinking that the group visit was kind of a necessary implementation for not only for the project, but for the clinic and the patients that we serve in this particular area. And so as a result, we've had a huge success for patients coming in, and this group is primarily Spanish speaking. And so we have a medical provider that participates. We have the behavioral health provider who also participates in that group visit. We have a health educator, and depending on the class itself, we'll have different guest speakers that come in: a certified diabetes educator, a pharmacist, and many other folks that do work with that group. So some successes in allowing us to work on this project. So, there were some bumps and bruises, but we definitely provided a lot around health literacy, educating folks on their diabetes. And now I'm going to go ahead and turn it back over to Dr. Kwan and to Dr. Chandra Brown-Levy.
Okay, Dr. Levy, if you could please move forward. Dr. Kwan is experiencing some slight difficulties.
I'm back. Can you hear me?
Yes, we can.
Okay. Chandra, do you want me to take it?
Yep, go ahead.
Okay. All right. So just a few closing comments on what we learned from this project. So as is very common in these types of projects, really less than 5% of patients with diabetes were engaged with the Connection to Health web tools. Some of the key barriers that we found were about the identifying team roles and resources. So who was it within the practice who had the time to sit down and guide patients through conducting the assessments, through conducting the action plans. And so that patient navigator resource really was very critical to this process. And navigators, of course, can do many things. This seems to be a key role for them to do with patients. There were also some concerns around patient literacy and health literacy specifically. So patients needed more assistance completing the assessments than the Connection to Health study team had expected. And so having someone who could sit down and help patients read and interpret the meaning of the assessments was very important. And then finally, identifying eligible patients. So who was it that could, or how was it that someone could identify which patients were suitable for using this tool, and how could that be communicated with the provider? And what we saw really is that this was a very manual process, and ultimately incorporating into registries and other sorts of health information technology systems within your practice to identify patients, identify what sorts of services they may benefit from, is something that I know MCPN is working on developing and improving all the time. And really we just want to highlight how wonderful Shansei was. We really found how important it was for him to really be really excited about this project and what it could do. He, as you can see, he just stood head and shoulders above what had been really happening at baseline. We really struggled there. And it was really in around this time last year that we said, things are not going so well here, that we really had to engage the organizational leadership in identifying who it was that could take on the role of doing assessments and action plans. And as you can see, once Sophia and Allison got involved, that things really improved pretty dramatically from that point on. But then people started to realize how important Shansei was to the practice, what a great asset he was, and so they started asking him to help with other things, and he had to spread out his priorities and spread out his effort a little bit more across all the different things that the practice was asking him to do. So patient navigators are a really valued asset. And Allison, Sophia, anything else you want to say about that?
About Shansei?
About the value of patient navigators.
Oh, yeah, I think that it's, as I said before, that it's really just, yeah, especially what we saw with Shansei is that if you have somebody that's dedicated to doing this, it helps leaps and bounds, not just with diabetes distress, but also just with linking patients to all those necessary resources, because, especially working in community health, so many of our patients face issues with their social determinants of health, and they greatly impact their physical health. And so having those people that are able to kind of come in and know all about the resources, it's an invaluable resource for our patients and for our providers, to have these people who are able to actually spend time, diving into some of these issues. So, yeah.
Great. Thank you. And then finally, around implementation, team-based care is now, and it's the future, but it's complicated. And figuring out workflows and roles, and figuring out who has time available to do what, and how you do the handoffs, that's not easy, and a lot of practices struggle with that. And one of the ways that MCPN really overcame that is by developing a whole model of care around their diabetes clinic idea, in which all disciplines collaborate to determine the care plan, identify and address barriers, identify resources, all in the context of a single visit where they each see the patient. And in which they are able to review the clinician report and flag relevant providers. And then, as Sophia mentioned, health information technology adoption. This isn't new, of course, but the lack of interoperability with the EHR continues to be a challenge. I think more EHRs are starting to recognize that they may need to be a little bit more flexible, that they may need to interface with other systems, but that is still an active area of development. And then sometimes these systems that you have, these external systems that you have, can be redundant with existing processes. And so in a future version of Connection to Health, it will be modular so that practices can select which pieces they want and which they do not. So with that, I think we have some time for discussion and questions.
Okay, yes, we do. We do. Our first question, and we will have a poll question. Poll question 4 will be coming up shortly, and then we will also review poll questions 1, 2, and 3. So the first question is, many clinics have a Hispanic patient population. Are there any screening tools specifically for the Hispanic patient population?
So this is a great question. We had the diabetes distress scale translated into Spanish, and not just directly translated, but reviewed by native Spanish speakers from Hispanic communities in Denver to help us change some of the language to make sure that it was culturally appropriate. So an example of that is we say friends and family in English, but we were told no, family comes first. You would always put family first, and so those sort of little details were important. And so we do have that diabetes distress scale in Spanish. It has not been officially validated, but we do have it available. And then the Connection to Health tool is also available in Spanish.
Was there also a question about the specific questions on the diabetes distress scale? I think I saw that.
Yes, that would be the next question, yes.
Okay.
So both the PHQ-9, I see somebody indicated here, the PHQ-9 is available in the public domain in many different languages. Not all of the languages, but many languages. I believe last time we looked for one of our clinics specifically, we looked for the top 5 languages spoke. One of them was Farsi, and I don't believe it's been translated into Farsi, but there are a lot of languages for the PHQ. For the diabetes distress scale, that's also available in the public domain. You can just Google it, actually. You can find it in PDF. But what it asks, it's a 17 item questionnaire that asks about how much you've been bothered or distressed by various things during the past month, and then you circle 1 through 6. It's a Likert scale. So I won't read you all the questions, but some of them are things like feeling that I'm not testing my blood sugars frequently enough, or feeling that I'm often falling behind in my diabetes routine, or feeling that diabetes controls my life. And then people can answer whether or not they feel like it's 1, not a problem, or all the way to 6, a very serious problem. So I would say you can easily Google that, and both of these tools are available for free.
And there's a note here that we're supposed to announce that they will have the diabetes distress scale, the PHQ-9 and PHQ-2 slides available to participants after the webinar.
Resources will be available on the Partnership for Diabetes Health Equity website, and that is, well, it is diabeteshealthequity.org, but there will be links provided at the conclusion of the webinar. So specifically regarding poll question number 4, which would be intentions to use diabetes distress assessments in workflow in the future. So we have over 50% say yes, they will begin screening measures. Any thoughts as to why this is necessary and relevant?
Why it's important to do those assessments?
Yes.
Yeah. I think our finding that most patients do not spontaneously identify distress or even depression as something that they prioritize as their top goals is important. And unless you're able to systematically identify when this is happening and then help to normalize that experience for people, I think just like mental health, there's likely some stigma around distress or any sort of psychological concern. And so doing that screening to identify who is struggling is very important, because in what we know from the research is that if you don't identify and address depression, distress, other sorts of psychological needs, that it's very difficult to take any action on those more concrete behavior changes that many patients identify as their priority need. And so unless you have addressed the negative feelings you have around your diabetes, addressed the concern and confusion you have around your medication, it might be very difficult to actually adhere to your medication. And so having a skilled provider who can engage a patient in that conversation with some data to back it up. Hey, we did a survey with you. It seems like you're really struggling. Can we talk about that? That can be an important step in the workflow to meeting patients' needs.
I would agree with everything that Bethany said, and I would say oftentimes people come in with the symptoms, but they don't have a way to identify what's actually going on. So even, depression, which we know a lot more about than we do about diabetes distress. Oftentimes people come in with symptoms, but they don't know that it's depression that they're feeling. And so being able to give that a word and say, this is actually, we have a lot of treatments for this because this is something that a lot of people suffer with. But even if we just looked at that, a lot of people come in and they say, okay, I feel like I'm just going crazy. And we say, no, you're not going crazy. There's something, we call this, we have treatments for this, you're not alone. And sometimes just that in and of itself is very comforting for people to know that there are treatments available and there are providers out there and teams who care about them doing well, and that there are pathways to get them feeling better.
Thank you, Dr. Kwan and Dr. Levy. Our next question is, before we address poll question number 3, some states have funding cuts and have fewer or no certified diabetes educators available. Neither do they have assigned patient navigators. How are the clinics managing this lack of professional education?
This is Sophia, and I actually would like to address this a little bit for you. Right now, here in the state of Colorado, we are looking at, there is a patient navigation collaborative that was had received some grant funding through our it's the Colorado Public Health and Education Program, basically the health department, and they are had provided a grant to look at what patient navigation can do for organizations that serve individuals who are underinsured, uninsured, and who have large issues with social determinants of health. And so this grant has been looking at how to make this sustainable, because they're actually offering training at no cost to organizations. Our organization has taken advantage of that and has sent all of our navigators through this training. There's a level 1, a level 2, and a level 3. However, what they're finding now is that they actually want to move this into the colleges and actually make these courses available to folks that are going through a healthcare track. For their education and their undergraduate's degrees. So we are working in partnership with them right now to adopt some of their scope of work, as well as develop some competencies that are all happening. There's the Community College of Otero schools out in Pueblo, I believe it is. And there's another school here, I believe Metro State University is also looking into putting this as one of their coursework. And some of the community community colleges are also looking at this as part of a course track. So Allison can speak more to that, but as far as, and I can give the mic over to her in just a second, but one of the things I did want to mention is that because we are a federally qualified health center, our funding is also very limited. We only have 4 general patient navigators throughout our entire system for our 25 locations, so they're stretched pretty thin. but we also have, we do work off a lot of with grants to help fund other positions. Our health education team has currently 3 CDEs, those Certified Diabetes Educators, and one of the things that we've been trying to do to really expand upon our services is partnering with other agencies in the community to see what they can do to help us meet the needs of the individuals that we're serving. So we've partnered with other organizations who are doing programs like the Diabetes Prevention Program, and they come into our organization and they work with our patients, and then we kind of take, those folks that are, in that top tier of people who are struggling the most to provide the education that we can. Unfortunately, yes, we understand what you're saying, and we're experiencing the same effects as well. But I think partnering with your agencies as well. And then I'll let Allison kind of speak a little bit about what the universities are doing and some of the community colleges around patient navigation.
Well, I think Sophia kind of hit the nail on the head with that, but I want to answer another question of how are the patient navigators different than the community health workers? So they're actually in the process of creating 2 entirely separate job codes, like federal job codes, because they are very different. So community health workers typically they are similar in that they are kind of entry-level positions, but patient navigators are individuals who are actually established in the clinic and have access to the EMR. Traditionally, community health workers do not have access to EMRs and do a lot more of their work actually in the community doing home visits. Patient navigators are clinic-based, access to EMR, work with the provider, are part of that care team on site. So that's a little bit of how they are different.
Wonderful, thank you. I think you all have addressed all the questions that we've had thus far from our audience, and that is actually all of the time that we have for today's webinar. If you are still on and you have any lingering questions for any of our webinar panelists, feel free to submit them in the presenter Q&A pod, and we will continue with the conclusion of this webinar. A huge thank you to Dr. Kwan, Dr. Levy, Ms. Sophia, and Ms. Dreyer. Thank you very much for an informative and highly educational presentation. Additionally, we thank each of you participants for attending today's presentation. These are the references. And again, today's presentation will be made available, presentation recording and the webinar PowerPoint will be made available at diabeteshealthequity.org, and you can connect with us at P4DHE using hashtag PDHE. Thank you and have a wonderful afternoon.